Today, I wanted to give some highlights from the Miami Cancer Institute Oncology Symposium. Vivi and I are sharing that responsibility. So I'm going to go over 3 of the sessions that we participated in. We're going to talk about navigating the safety maze of oncology rehabilitation, the malnutrition session for oncology patients, and head and neck lymphedema session. So we're starting with, it's actually the first session of the day, the cancer rehabilitation, navigating the safety maze in cancer care. This was provided by Morande, and he is part of the staff at Miami Cancer Institute. And before I get to that, it was interesting. He talked about how the cancer rehabilitation is more of a maze, which I found was interesting because a lot of times we talk about rehabilitation, say after surgery or after a hip replacement or after just an illness, as a progression, kind of more of a straight line or in beginning and end point. But he talked about it being a maze because as people go through their journey of cancer treatments, they're going to come up to either chemo, then radiation, then or surgery, and then healing from the surgery, and then maybe more chemo, or maybe something else comes up. So it's really kind of a maze for them. So interesting statistics, the population of cancer survivors is expected to grow by 31% over the next 10 years. So we have a growing population of patients in this category. And there is a gap in rehabilitation care for cancer patients. Impairments and symptoms, decreased function, decreased quality of life, decreased work capacity. And despite the amount of cancer-related impairment, referral rates for even simple treatable physical impairments were only reported to be as low as 1% to 2%. So we definitely have room for improvement when it comes to comprehensive cancer care as a whole, getting these people rehabilitation. So rehabilitation should be considered throughout the continuum. Especially interesting is the idea of prehab, which can help maintain function during treatment. So if you notice the model of rehabilitation here in the continuum of cancer care, we have, a time period of, say, prevention up to diagnosis, potential surgery, radiation, chemo, that active treatment time to the end of life, of course, and that's the whole spectrum of survivorship. But prehab can come in even before or at the time of diagnosis, prior to the start of treatment. And then, of course, during treatment or after, you have restorative support. And then at the end of life, you still have palliative considerations that rehabilitation can offer as far as managing symptoms of their disease. So it really can be a whole spectrum. It's not, rehabilitation's not designated only for after treatment ends. And as I was saying, pre-treatment risk assessment, she kind of go over some of those parameters: baseline physical and functional status, prediction of mortality, disease-free survival. In a perfect world, we'd have a comprehensive functional assessment prior to cancer-directed treatment, optimize performance outcomes, in hopes to optimize performance outcomes during and after treatment, identify early functional decline. And that's something certainly that we could consider, prehab, or maybe a change in the NIU program, or something that we do through the multimodality clinic, just as that baseline functional assessment and potential there to recommend a referral to rehab. So my question, could there be an opportunity to work this into MMC, even using the SOZO refer into a class or refer directly to physical therapy if they have significant deficits. Safety considerations with cancer treatments. There are many health concerns to consider when we are having people exercise during or after treatment. We have hematological compromise, you have cardio pulmonary toxicity, neurotoxicity, lymphedema, the effects of radiation, bones, certainly if they have metastatic bone disease or effects of the treatment to their bones, and then advanced cancer. So certainly safety comes first when it comes to these patients. So she gave a nice table, which I thought was very interesting, a good kind of reference point for knowing lab values. So for this is example of platelet counts. And you see with, very low platelet counts, it may not be necessarily appropriate to have them exercising. You may need to hold therapy. As it kind of goes up a little higher, less than 20, with permission of the doctor, ambulation, self-care, minimal or cautious exercise, light programs. And as you kind of get into better numbers, then we have more functional mobility, more exercise options for these frames. So I think this is a kind of a good chart to keep in mind and to keep as a reference point for this kind of patients. For patients with anemia, you can certainly have reduced exercise tolerance and endurance. You can lead to fatigue, to dizziness, to hemodynamic instability. You want to watch that functional, exertional status, watch for symptoms, chest pain, lightheadedness, difficulty breathing, dyspnea. So that's something to consider. Neutropenia, of course, low neutrophil counts can compromise their immune function. So there's no compelling evidence that rehabilitation interventions are contraindicated. Certainly monitor for some of the same considerations: fatigue, malaise, dizziness. Therapy should be based, of course, on the patient's symptoms and be alert of any early signs of infection. So in these population, we may not necessarily be recommending patients go to an open gym where there's more risk of picking up germs. But, certainly exercise is still an important part of their treatment. Cardiopulmonary toxicity in advanced cancers, somewhat related to cardiac cachexia. It's just the cachexia is a loss of muscle, and that can happen to any muscle. And certainly in this case, it can happen to the heart. Anti-neoplastic radiation treatment to the chest wall can affect the heart and the pulmonary function. Different types of chemo meds can have an impact on cardiac function, anthracyclines, reduced left ventricular function, reduced overall ejection fraction, compromised cardiac function. Trastuzumab can cause systemic edema, shortness of breath, dyspnea. Bleomycin and MTX, pulmonary inflammation. So certainly the effects of these medications can have effect on cardiopulmonary. So, again, watching the vital signs when prescribing exercise for this population. Consider risk factors, prior cardiac comorbidities, monitor for edema is definitely necessary. And kind of monitor for the difference between that cardiac edema and lymphedema. Neurotoxicity, continued screening for balance changes over time, observation of gait deviation, triage for rehabilitation intervention to manage emerging impairments and is recommended. So severe neuropathy with motor changes may significantly kind of affect safety and may need intervention to mitigate kind of that balance. So if we get a loss of feeling in the feet or hands, that can all kind of affect how they function. So falls programs are important in this assisted devices, things like that. So, and this is very common for our patients to get that neuropathy, that loss of feeling. So these rehab referrals are important to kind of get them in with our professionals, with our therapists and stuff, and setting them up with, the safe assisted devices or certain types of exercise that can reduce the risk of falling, work on balance exercises, gait, these kind of things. So lymphedema is also very common. New onset is an important safety concern. So always there's a risk of another reason they're having that swelling or edema, a DVT, cancer, infection, but safety of exercise and lymphedema, any signs of redness, pain, worsening of the swelling should be referred for further workup. But it has been shown that a little bit of exercise, light weights can be helpful actually with lymphedema. So it's something to still consider. And of course, when they have bone mets or osseous fragility, know their weight bearing status to protect the bone, but you want to protect the affected bone, promote strength and mobility, of course, using assistive devices and equipment to provide safety, joint protection. Bracing is indicated in patients with spinal instability. Exercise programs should avoid high impact torsion or manual resistive exercises. I think my biggest takeaway from the safety concerns is more of, are we doing enough as far as screening for these kind of issues for just the general class or just maybe even the UU program or something where it's very much more casual. Are we really looking at all these kind of things? Should we be doing more of screening out or knowing their status? I also am thinking, could or should we be tracking actual rehab referrals as part of our program? Knowing how many patients are being seen by rehab and how often are they being referred, and kind of promoting that portion of a rehabilitation program. Sending them to the professional and a full physical therapy assessment and monitoring so that they get all these kind of professional oversight. So certainly it's possible, when people have bone mets, it may not be good, no manual muscle testing in affected limb, no progressive resistance exercises in that progressive limb. You want to kind of offload weight bearing through the affected limb with an assisted device, avoid excessive spinal flexion, extension, rotation. So obviously a role of a brace, monitor for increasing functional pain. So all of this kind of is consideration for a physical therapy or professional to kind of go over the patient and know. And certainly if we have a patient coming into one of our classes, that might be something that we kind of need to know if they have bone mets or restriction on weight bearing and things like that. So rehabilitation is generally safe. Their conclusion was in cancer patients, but there are numerous important considerations in this population. Rehabilitation provides therapeutic intervention that may mitigate loss of function and disability in cancer survivors. So it's something we certainly need to be encouraging and pushing through our program. So moving on to the malnutrition and its impact on muscle mass in the oncology population by Nicole Rittman. She was a dietitian at the MCI. So the impact of malnutrition is slightly different in the oncology population than the general population. So the general population malnutrition is going to impair wound healing. It's going to increase the risk of infection. It can increase the length of stay for hospitalized patients. We kind of know this. But for a cancer patient, you have similar effects, but you have increased risk of toxicities from the treatment. You could have poor treatment tolerance, decreased prognosis, and decreased quality of life. So being able to impact and intervene in malnutrition in these patients early is, of course, our goal. Now, we probably don't talk about it a lot, but there is a very specific, there's multiple different definitions of malnutrition, but the Academy of Nutrition Dietetics and the Aspen put together malnutrition definition, and that definition is basically the presence of two or more of the following conditions: decreased intake, weight loss, muscle mass loss, fat mass loss, decreased functional status, and fluid retention. So it's interesting though. So none of those are lab values. None of these are particularly biological nature. So decreased intake, that definition is less than 75% of nutrition needs in 1 month. So any decrease in typical intake is going to kind of qualify in this definition. Weight loss, we have multiple different categories here, but 5% weight loss in a month, 7.5% in 3 months, 10% in 6 months, 20% in 12 months. So, this is why on our distress screening form, we've inserted the malnutrition screening tool, which very simple, 3 questions. But the primary question is, do you have a decreased appetite? So that's going to cover that decreased intake. And have you lost weight recently? So that is 2 most common criteria for malnutrition. Muscle mass lost is usually seen a little bit more of a nutrition-focused physical exam or visual. So you can look at mid-arm circumference. It's a very old method for muscle measurements. The DEXA and CT is not quite as so available and realistic. I guess there could be a potential for using the SOZA by kind of under that criteria, bioelectric impedance. But we do tend to use the nutrition-focused physical exam the most, looking at the eyes, the temples around the eyes, the face, the cheeks, your clavicle, your backbones. You're just kind of watching for that decrease of muscle and fat under the skin in those losses. Again, the same thing, fat mass loss is nutrition-focused exam. Now, decreased functional status, actually, interestingly enough, they use a grip strength with a hand grip dynamometer. And it was actually using this type of measurement in our old senior optimization study, which never really was viable, unfortunately. But it was one way of measuring a reduced amount of strength. And basically what they find is if you have reduced hand grip strength, you have a reduced overall upper body strength, and that kind of relates to malnutrition. And of course, with fluid retention, patients who are having edema or swelling and stuff, it could be related to loss of muscle and albumins and things like that that hold the fluid in. So there is a difference between sarcopenia, cachexia, malnutrition. So sarcopenia is a decline in muscle mass. It's a decline in muscle strength. It's decline in functional performance. So some of the same criteria, but not necessarily with weight loss. So we can have sarcopenia found gradually in our aging population, and even in our obese population. And it's certainly a concern, again, because that malnutrition, sarcopenia can relate to a decreased wound healing and decreased increased risk of infections and longer hospital stays and things like that. Cachexia is the presence of this muscle loss, so the same in the presence of weight loss, not necessarily with the fat loss, and much less controllable, unfortunately, when you get to this significant sides of cachexia. So for us, just in general, and probably more so important for the dietitians than our social workers, indirect calorimetry has always been the gold standard, which is why Brandy has been pushing her indirect calorimetry for her patient population, and really would be great if we could expand that to our treatment patients and higher risk patients as far as malnutrition. So we get that best, but her energy needs, as far as our typical estimation, 25 to 30 calories per kilo for body weight is what she's really kind of looking at. For protein needs, 1.2 to 1.5 grams per kilogram. And for the social workers and reference point, for you guys, it would be more of 0.8 to 1. The 1 to 1.2 is kind of the more aging population. So you want at least 1 gram, but we can go up to 1.5 in our patient. And actually some patients, we go as high as 2, particularly like our head and neck population, or populations that have a significant weight loss and significant healing needs, significant skin repair, all that kind of stuff. So definitely you want to assume a normal kidney function, of course. So, and of course, she gave an example here. What I found most interesting about her presentation was this slide: estimating nutrition needs, other considerations, evaluation for possible insulin resistance. So if suspected, consider shifting some of the calories from carbohydrate calories to fat calories. And I think that's very possible with a lot of our patients, because a lot of our patients will be on some type of steroid during treatment, or have that a history of like borderline diabetes or insulin resistance, or be overweight or obese. And in those kind of cases, compared to our typical, carbohydrates at 45 to 65% of calories and fat only being 25 to 35% of calories, she's kind of recommending more 45% at the lower end of that carbohydrate range, and using the higher end of that range for fat. If you notice in the green square over here, that would be her recommendation. Now, this is kind of more specific to patients who would have insulin resistance or on treatment or something like that. There are certain populations where we have studies where very low fat diets can reduce the risk of recurrence, and that is typically our breast population. But for a lot of the other populations, this might be of consideration. So she talked about some individual nutrients that's been studied as far as malnutrition. Omega-3 fatty acids found, certainly can decrease inflammation, found to decrease resting energy expenditure. However, when they do systematic reviews or studies, they show no impact on muscle maintenance, quality of life, or body weight in cancer populations. So still kind of on the fence or questionable as far as if fish oil supplements themselves is going to help with cachexia or malnutrition. Maintaining muscle mass strength must be a collaborative approach. So malnutrition is a multifaceted condition, requiring that multidisciplinary approach. And as medical providers refer to clinical nutrition for assessment and implementation of recommendations, and for us clinicians refer to rehabilitation services to assist in that functional status. So really, obviously, a team approach. If they need that rehabilitation, you need the proper fuel going in with the exercise to rebuild that muscle and that muscle strength. So that was pretty much her presentation as far as malnutrition, and pretty consistent with what we do, generally speaking. But an interesting session with the head and neck cancer related lymphedema. What should you know? And this is Carolina Gutierrez, also part of MCI. So obviously she kind of reviewed the lymphatic system itself. The lymphatic system maintains our fluid homeostasis, essential for the immune system and surveillance. And in cancer patients, metastasis is often occurs through the lymphatic, so it can travel through the lymphatic system to other locations. And about a third of the body's lymph nodes are located in the head and neck region. So very interesting. The whole third is in that just that one section of the body. So for head and neck patients, they would find neck swelling to be a common symptom of lymphedema. Tightness, neck asymmetry, meaning, both sides of the neck doesn't look the same. Swelling, limitation in range of motion, stiffness, firm or hard skin, changes in voice, difficulty swallowing, shortness of breath. So, and a lot of these symptoms could be misread as something else, just radiation side effects or something with their cancer itself. So it really is hard for this population to kind of really be able to see the lymphedema because they don't have a opposite side of the body to compare to. So like, for instance, breast cancer patients who get lymphedema in an arm have another arm to compare to, or another hand to compare to, or legs or hips. But in the neck region, it's much more difficult. So internal, external lymphedema associated with symptom burden, functional deficits, decreased quality of life, of course, body image issues. But so there's the lymphedema severity, decreased cervical range of motion, so decreased range of motion in the neck. Combined effects of external and internal severity can even decrease hearing and overall quality of life. So certainly, like I said, you have the swallowing difficulties, self-reported weight loss or nutrition impact symptoms. So patients cannot be their own control, as I was kind of saying, for head and neck lymphedema. Upper lower extremity lymphedema, you can use kind of that contralateral limb as a control, but you don't have that. And you also, it's hard to tell where changes in the neck are coming from, because the patient may have also experienced weight loss. They have a change in their anatomy from surgery. They get fibrosis. There's a lot of different things going on in their neck region to be able to kind of differentiate that lymphedema. But she talked about the treatment for lymphedema, which definitely looks medieval, but interestingly enough, can be effective. So this is called complete decongestive therapy. Of course, there's education and training involved, skincare. Part of the treatment is manual lymphatic drainage, compression, bandaging, and garments. And this is a pneumatic compression device that kind of does that manual lymphatic drainage and stuff for the patient. So they also talked about how they can really kind of see the lymphedema, the lymph drainage. So there is a imaging test called the near infrared fluorescence lymphatic imaging. And this does happen in this area. Some of our lymphedema specialists are able to see these kind of tests and imaging. So for this patient, this would be normal lymph drainage. So if you notice from these areas that light up, come all the way down and drain down the neck. In some of our head and neck patients, you'll notice you get this enhancement with nothing. So in this case, that those lymph nodes are not draining. So that's pre-treatment. And then with post-treatment, you can see that they're starting to drain. You get some enhancement in the neck, and it's starting to drain a little bit more normal. Not perfect, of course, but a little bit more normal. So these kind of treatments and use either of the pneumatic compression device, the manual lymphedema drainage. They did do a study of 205 head and neck cancer patients. They did an at-home use for about 90 days on average, pre and post treatment. So they had improvement in ability to control the lymphedema. They had an improvement in their ability to perform other daily activities, decreased head and neck pain and discomfort, decreased difficulty when swallowing, decreased difficulty when breathing. So certainly some of these results are significant and helpful in this population. So that device, this one, is actually available through DMEs. Pretty much available through Tactile Medical. And they have a whole referral process for prescribing the lymphedema therapy, and referral form to fill out and send their way. And then the company works with insurance and provides education and demonstration to the patients. So certainly something to consider for our head and neck population that may be experiencing this lymphedema. It is prevalent in the head and neck population. It can interfere with function and quality of life, and lymphedema can and should be treated. So treatment of head and neck cancer-related lymphedema can have a positive impact on function and quality of life. And certainly with this population, any little benefit we can give, any improvement in their quality of life, because things just get so difficult for them, is significant. So, and then imaging with the near infrared technology is an important tool for visualization of the lymphatic system, and just kind of see the benefit and the results of what was being done. So those kind of some of my take homes from the MCI Symposium, and thank you all very much for listening.